Good afternoon. My name is Russ Derry. I'm the Pediatric Epilepsy Program Manager at Mott Children's Hospital. Thank you for joining us today. Today's Epilepsy Expert webinar is entitled Epilepsy in Adolescence, and we're thrilled to have with us Dr. Eric Armour, who's one of our pediatric epileptologists here at Mott Children's Hospital. He's also the Epilepsy Fellowship Program Director. So with that, I will hand it over to Dr. Armour. Just as a heads up, we'll have about 10 to 15 minutes at the end, at least, for Q&A. Until that point, if you can keep your camera off and keep yourself muted for that period of time. In the meantime, during the presentation, if you do have any questions or comments, feel free to add them in the chat. So we'll go ahead and get started. Thanks, Dr. Armour.
Hi, my name is Eric Armour. I'm one of the epileptologists here at Mott's Children's Hospital. I specialize in epilepsy and am the program director for the Epilepsy Fellowship, as Russ said, and I also am the director of the Tuberous Sclerosis Center here at Mott's Children's Hospital. So I'm glad to be with you today and talk about epilepsy in adolescence. I'm going to go over a large overview of the many different issues that can come up with patients with epilepsy in adolescence. But at the end, there's going to be plenty of time for specific questions or follow-up to any of the topics that I brought up during this talk. So save your questions for the end. There's going to be a lot of time to discuss specifics or questions you guys have. So today I want to sort of talk about three different areas that can come up when there's a transition of care and transition from childhood into adulthood. And that time of adolescence can be with a lot of changes. And so I want to sort of address these main areas. First, medical transitions, talking about changes to medications, changes to the doctors that you're seeing, the relationship with the doctors and the relationship between the doctor and your adolescent patient, and a little bit about lab monitoring and why things might change from childhood into adulthood. Legal issues, I want to briefly talk about some legal things that might come up in the transition from adulthood or from childhood to adulthood, specifically driving and guardianship. While I'm not a lawyer, I do take care of a lot of patients who go through this transition. And so I want to make sure that you have the resources you need to make those decisions and if you have any questions of who to contact. And then finally, which will be, I think, a little bit longer portion of the discussion, will be social changes. Things like independent living, seizure triggers in adolescence, and then vulnerable populations in certain patients with epilepsy. So, and then there'll be plenty of time for discussion and questions afterwards. So during adolescence, there are a lot of goals of both patients, the kid going through this change, and their families. With patients with epilepsy during adolescent period, all the normal development that is going along with the stress and change of this time is still happening. And so kids are learning how to navigate friends, relationships, romance. There are a lot of emotional changes going on during this period. Children are starting to learn how to transition to independence in their daily routines. And going along with that is negotiating dynamics with parents and teachers and trying to figure out where they can be autonomous and where they can have agency and where they need guidance and support from their there's any figure in their life that's supervising them in any role or in a position of authority, and a lot of conflict with that during that time. And then also continuing with school and education, sports and activities, and planning for the future, stressors about whether or if they're going to go to college, what kinds of jobs they want, what kind of career they want going forward. All of those things are going on with these patients as well. And so learning how to deal with those stressors and goals while also addressing specific things for patients with epilepsy. And so some of the things that need to happen during adolescence for patients with epilepsy is learning about and taking ownership of their epilepsy, being able to understand what's going on with their brain and their body, but also not sort of making sort of taking on epilepsy and epilepsy patient as their identity. There's a lot of other facets to their lives, and so sort of integrating their diagnosis with who they are, learning about their epilepsy treatments and taking sort of ownership of that. Managing seizures in daily lives. As above, continuing school, sports, and activities is really important. And so learning how to integrate sort of safe practices into those activities is really, really important. And then adapting to their work, school, and living situations with epilepsy as well. So the first area that I want to talk about are medical issues, and each patient with epilepsy is unique and they're going to be on different medicines. And so I want to talk sort of in broad strokes about what might be encountered during this time. And if there are specific questions, you can save them to the end, but you might need to talk to your specific neurologists to get a tailored explanation specifically to your situation. So medical situations and medical transitions. The first and most important, I think, is making sure that adolescents are empowered to take as much control as they can over their diagnosis and over their treatments. And so that begins at home by talking to the teen about their diagnosis and sort of what their medical course that they may have different sort of memories of as they're maturing, and sort of making sure they understand what has happened in their life so far and what is sort of involving their current treatments. And then when they get to doctor's appointments, encouraging your adolescent teens to participate in the appointment, ask questions in their appointments. Sometimes I've found it very helpful to have parents encourage teens to write down questions as they come up over maybe the week before their appointment, so they can start not only learning about their own condition, but having some agency in discussing that and bringing up areas that they're worried about and their concerns. And this is really important for any patient, but specifically in the adolescent patient, where parents have often been really driving a lot of their care and questions, and sort of allowing that time for the patients to start thinking about what they want to know and what are the biggest concerns they have going forward. Another way to empower adolescents is giving them graduated independence of treatments. And this is going to be based on the patient, what their cognitive abilities are. Patients with developmental delay or intellectual disability will likely have less sort of autonomy over their treatments. But it is important to start giving adolescents the opportunity to sort of take their medicines and take responsibility for that, because what we do know is that patients who haven't had that and then turn 18 or 21 and are living on their own, and they haven't been involved in that from a relatively early age and early adolescence and into adulthood, that large transition can be a lot to take on. And so gradually offering more and more autonomy in that is really, really important. And I put here trust but verify, because adolescents and all kids can say they're going to do a lot of things. Recently, I learned that a nephew of mine, his parents had been telling him to go brush his teeth and go to bed for the last year, and they had not been verifying, but they were very good on the trust part. But his recent dental visit showed that he had not been doing what they had been hoping. So it is important to give them sort of control over and reminding them to take medicines, but there are ways to both help them and you to verify that they are taking their medicines. Pill boxes are a really good way to keep track of missed doses. And if there's a question of whether or not kids have taken their medicines, checking the pill box is really, really helpful. Another thing that can alert you that there might be some missed doses, or your teen isn't taking their medicine, is the timing of refills. A refill's due, the pharmacy calls you and tells you you can pick it up, and there's still a third of the bottle of medicines left. So those are two specific ways that you can use to better verify that your adolescent is taking medicines. But often this is just a ongoing conversation. And when a kid is 10, 11, 12, this is likely not going to be easy or always remembered. But when we're nearing 17 or 18, we're hoping that we've built the habit that this is going to be ongoing. The other way I think empowering your teen is sharing what they feel comfortable with friends. And I'll talk about this a little bit at the end about sort of stigma with epilepsy, but making sure that they feel comfortable with what they know about their condition, and sharing it with friends is a way for them to feel less isolated, but it's also a way for them to sort of solidify what they know. They're teaching other people about their epilepsy, and so their friends might ask questions and spur ideas of what they can ask their doctors or their parents about, and really help them take ownership. But I think sharing what about their condition can be really empowering, and make it less lonely for them, because they know other people who they care about sort of know this part about them. Continuing with sort of medical things to think about during adolescence is there likely is going to be changes to medications during adolescence. First, patients are growing, and so moving from the childhood time where kids are growing rapidly, often medicines are weight-based in the younger ages, and so we are as they continue to grow, they will continue to have dose adjustments of their medicines, and they will be getting closer to adult doses. But second of all, the metabolism of teenagers is different than in children. Some medicines are metabolized faster, other medicines are metabolized slower. And so there may be, unfortunately, breakthrough seizures just because the dose isn't quite as right for your child going forward. Also, side effects of medicines can change with aging. Usually, it's not dramatic, but I have seen it, and we see it occasionally. And so, a new side effect should always be discussed. It's not always going to be directly related to the medicine. It might just be part of the maturing and adolescent process. But anything that you're concerned about should be brought up with your physician. Because of the changes in metabolism and weight, you might need more lab monitoring. You might need to check medication levels, and medication levels can be helpful both in the dosing of certain medications, but it can also be in the teen who's taking on more responsibility. For their dosing of their own medications. The medication levels can help both parents and providers know if their child is taking the medicine. I just sort of want to say that there aren't very good guidelines about specific times to measure medications. And so this will be an ongoing discussion between you and your provider. But some medicines, and I can give some examples like lamotrigine or valproic acid or valproate, can be really helpful in getting levels and adjusting medications based off of the levels. On the other hand, other medications such as levetiracetam is a good example, is the level of the medicine might not be as helpful in dosing, but it can be really useful in understanding if the medicine is being reliably taken. So there might be more labs or medication levels that are needed during this time. During adolescence, there can also be changes in seizure frequency, and this can just be due to sort of changing of the epilepsy, but we see some children as they go into adolescence have worse seizures, some kids have better seizures, and some kids don't change at all. It's very variable, but I would not be surprised if the seizure frequency does change during adolescence. And I wish I could give you as a group, better guidance of what to expect. But I think the most important thing is to expect change, and that's okay. And we will continue to make changes based off of that. You might need to make medication changes in adolescence depending on specific circumstances. And so as an example, valproate is one of our best medicines for especially generalized epilepsies. It's an incredible medicine, but it does have side effects, and those side effects tend to be more noticed in teenage years with all of the other changes that are going on. Things like weight gain or hair loss or things like that can be more sort of noticed during teenage years where there are changes to the body and kids are feeling more self-conscious, but they also for older teenagers who are becoming sexually active or might get pregnant or are planning to get pregnant. In those cases, we would want to have a frank discussion about certain medicines, especially valproate, which can cause birth defects. And so that's going to be a discussion with your provider about whether or not they should be on that. When kids, especially young women, are getting older, there often will be a discussion about birth control options. Certain medicines, like I said, valproate is one of them. There needs to be a discussion about potential birth defects from that medication. But also at this age, patients, regardless if they have epilepsy or not, might be going on birth control. And the other reason to discuss it is that certain medications like phenytoin or carbamazepine can reduce the efficacy of birth control. And so there's a higher failure rate of birth control, especially oral birth control, in those patients on those medicines. And so discussing that with your provider and letting your pediatrician or primary doctor know about other epilepsy medicines you're on is really important. On the flip side, starting oral contraceptives can also affect levels of seizure medicines. And so you might have breakthrough seizures if those medication levels change. One example of that is starting oral birth control can decrease the level of lamotrigine. And so, again, having that conversation with your provider to make sure that we are adequately checking those levels and having discussions about what to expect. The recommendations from the American Epilepsy Society is that all women of childbearing age who are on seizure medicines should be receiving folate supplementation. And so that is often just an over-the-counter purchase for folate. That's an over-the-counter vitamin, but that's another discussion to have with your epileptologist or neurologist. Moving from the medicines specifically to changes in the interactions with your physicians or providers, as well as which providers you're going to be seeing can change in adolescence. And so it's always good to start the conversation early. Plan ahead for that transition to adult. You don't want to hit whatever the age cutoff from your clinic and then have to quickly find a new provider. So start talking about it early. There is a variation in practice about how old patients can be seen in certain practices. So, so have that discussion and have an idea of when you might need to transition to an adult provider. Another important thing to discuss is where to get adult neurology care. Adult neurology providers are often easier to find locally in your community. And so finding a provider that might be closer to you can be helpful if that's something you're interested in, but also making sure that those records and tests and EEGs and MRIs and anything else you've had done are sent along to that provider. Alternatively, you might want to stay within the same system because of the ease of communication between those providers, and that's okay too. But it just needs to be planned ahead of time. There needs to be sort of a discussion for whether or not you need to see other specialties, like I mentioned, adolescent medicine or OBGYN, talking about birth control and other medications that might be altering levels of medications is important. And then depending on what kind of epilepsy your child has, they might need to see other providers. For example, in some of my patients with tuberous sclerosis, as they get older, they're more and more likely to need to see nephrology or pulmonology, while they might have not needed to see that in childhood. And then I would encourage both parents and their teens to ask for time for one-on-one with the provider and patient. Often there are certain concerns that the patient might have that they don't want to share in front of their parents. But also it's good to sort of, again, empower them to take control of their epilepsy and to bring up things that as providers, we might speed through certain things or ask specific questions that we're interested in, but we aren't giving the time. Unfortunately, we often are at fault for this, but we don't maybe give enough time to hear specifically the concerns from the child. And so that's a really good opportunity. But expecting that there may be one-on-one time between your child and your provider, I think is a really sort of good way to both empower, but also give that safe discussion about any concerns they might have. So moving on from the medical issues to the sort of couple legal issues that you might come up in an adolescence with epilepsy. Driving is always a really big question, and there are many different resources that you can look up for driving with epilepsy. I think the Epilepsy Foundation has one of the best resources, but there are many different options. This is a chart that I pulled directly from the Epilepsy Foundation website. You can put in the state or states that you are interested in comparing, and it will pull up the basics of driving laws in that state. Here in Michigan and our neighboring state, Ohio, there is not a requirement for physicians to report epilepsy to the DMV. However, there are rules. Here in Michigan, it is 6 months of a seizure-free period. And there are some exceptions, but for by and large, it's 6 months of seizure-free before driving. Some states have longer periods of up to 12 months, or I think one state might have 2 years. But there are some states that have longer requirements to be seizure-free. And then other states have requirements for physicians to report and physicians to give clearance before driving. And so each of those sort of steps of getting a driver's license and being able to drive can vary by state. And so knowing those for your state is really, really important. This is a great starting point. Again, I'm not a lawyer, but here in Michigan, because we aren't mandated to report, we usually don't have to provide notes or things like that to be allowed to drive. And in the chat, there are also some bills that are being proposed to modify the existing restrictions and appeals. So that's great to know. Thank you for sharing that. The other thing I wanted to mention is that especially some parents, might have a lot of anxiety about letting their child with epilepsy drive. There are many studies sort of on this, but for a kid who has well-controlled epilepsy, yes, there is a risk, but compared to other medical conditions, it doesn't look worse than other medical conditions, and probably for well-controlled epilepsy is actually safer than other medical conditions. The best example I have is poorly controlled diabetes, and the fluctuation of blood glucose can actually be a much more dangerous change in mental status and risk for accidents than compared to epilepsy. So there is justifiable sort of concern about driving and seizures. However, it in comparison to other things that people drive with, it may not be at the top of the list. So just to alleviate some of your fears. Another legal issue that comes up especially in kids with epilepsy who have significant intellectual disability or developmental delay. There are many options for support. Guardianship is one end of that, but there are sort of graduated steps, supported decision-making arrangements, power of attorney, advanced directives, and then in some of the more severely affected patients, guardianship is a very reasonable option. It can be a long process, so starting that discussion early, well before your child is 18 is helpful. Talking with social work, the Epilepsy Foundation and legal aid organizations can really help. Usually what that requires is an application for guardianship, a letter of support from physicians, and then it goes to a judge, and there's usually a pre-trial or pre-hearing appointment where they make sure you have the right documentation, and then you go in front of a judge and sort of explain why you need guardianship. There are many other options that are less than guardianship, which is pretty much sole decision making in the guardian or the ward. But having those discussions early and not waiting till you're 18 when you're kicked out of the portal and all of the other things that come with reaching adulthood is really important. Insurance, same thing, start early, talk to social work. The Epilepsy Foundation and legal aid organizations can help, whether your child needs to get onto or stay on Medicaid versus private insurance, making sure that coverage and their medications are covered over that transition is really important. The last part of this talk is sort of social changes in your teen's sort of life and what they're going through, and difficulties navigating that with epilepsy. So one of the more common things to be discussed is independent living, whether that's going away to college, moving into an apartment, going on camps, going to summer camps, trips. Always safety first. Reminder of sort of basic seizure precautions, water safety. So if somebody is living alone, and even if they're not, probably recommending showers instead of baths. Not if they're on a summer camp, having expanding making sure there's a lifeguard watching the child during swimming at a summer camp. Most activities, are okay for patients with seizures, but discuss if there's any concerns. Things like skydiving, deep sea diving, things that you could be rock climbing without proper restraints. Those things can be dangerous for patients with epilepsy. And so discussing that with your physician is really important. When planning for college, some of the things that come up is the discussion of whether to have a roommate or a single. I've had patients go both ways, and I try to sort of help advise them as much as I can. Some patients, I think, if they're still having frequent seizures, having a roommate is often safer because there's somebody to alert if anything happens. However, some patients with maybe juvenile myoclonic epilepsy and are very sensitive to sleep disturbances might benefit from a single. And so having those discussions about what the risks are and where to live is really important. In addition to the water safety and activities, reminder, the driving precautions, and that with independent living, there can be often more missed medications or things like that. And so if you do have a seizure, it would set back the clock to drive for 6 months. And so that can be often a motivating factor to make sure that they keep taking their medications. Having a roommate, friend, RA, chaperone, know what to do in case of a seizure, have that seizure action plan, explain what's going on with their friends and people they are nearby. Often in college, kids will be, or teens and young adults will be carrying their rescue medicines on them. So having friends who know how to administer that if something happens. And monitoring devices is often a question that I'm asked. There are seizure watches and other devices that can alert for a seizure. And so depending on the type of seizure and sort of what the living situation is, those can be helpful in giving both the patient and their parents some peace of mind if they're not available for all types of seizures, and they aren't always covered by insurance, but it's something to discuss. Triggers in adolescence, like I was talking about, moving on to a more independent living. Missed medications are really, really common cause for breakthrough seizures in this age group. So encouraging consistent taking of the medications, especially for kids going away to college, but also just all teenagers. Teenagers have delayed sleep cycles, and that is part of their biology, but our school day does not go along with the biology of teenagers. And so kids like to stay up late, but then they have to get up early for school. And so really important to stress good sleep hygiene and encourage that. Decreasing screen time an hour or two before bedtime, going to bed at consistent times. Especially in college, kids will often be on a normal schedule during the week and then get their sleep very disrupted on the weekends. Encouraging them to stay on as much of a consistent sleep schedule as possible, and warning about seizures if that gets broken. Especially in high school and college, alcohol and drugs are definitely something to think about. Alcohol not only increase on its own increases the risk of seizures, but it also disrupts sleep and causes patients to be more likely to forget taking their medicines. So multiple reasons, not to mention that alcohol can also affect the metabolism of other seizure medicines, and other seizure medicines can interact with alcohol. So lots of reasons to avoid that. Drugs, there are, too many drugs to name, but many of them can interact with seizure medicines or decrease seizure thresholds. So that's something to remind. And then I put in here supplements. Most supplements are safe, but especially here in Michigan, where marijuana is legally available, it's another reminder that yes, we use CBD derivatives, especially CBD oil, to treat seizures. Things you buy from the store are not just CBD. There's often very, very high levels of THC, which in and of itself can be a proconvulsant. So some kids will try to sort of treat their own epilepsy with marijuana purchased in some of the dispensaries around. I definitely do not encourage that. And in addition, the things like Epidiolex, even if it's an over-the-counter dispensary provided CBD oil, it still has the same side effects. So there are still side effects of liver enzymes interacting with other medications, things to watch out for, even though you can buy it over the counter. And then stress is a big one in teenage years. There's going to be stress from all of the things that are changing, in addition to their schoolwork, their plans for the future, and then having epilepsy. So managing stress is very important. I want to talk about vulnerable populations, especially in our kids with epilepsy. There are higher rates of intellectual disabilities, and unfortunately, abuse of all kinds is higher in children with chronic illness and intellectual disabilities. And so this is an unfortunate reality, and we need to be, both providers and parents need to be watching for signs of this. There are a couple things that we can do and encourage the patients as much as possible for kids who are intellectually, who do have intellectual disabilities. Helping them as much as they can protect themselves, educating them about their bodies, about their body parts, using correct names, and helping them sort of have an understanding of what is appropriate and inappropriate behavior, explaining what abuse is, and then along with that, maximizing their communication. So whether that's a facilitated communication device, whether that's speech therapy, whether that's other types of therapies to help them communicate if something is going on that their caregivers aren't or physicians aren't aware of. Also, reducing social isolation is one of the things that we know helps prevent abuse. And so kids who are with epilepsy, this is another reason that we encourage continuing as many normal activities, sports, clubs, things like that, really getting them involved in their community as much as possible. And for the intellectually disabled kids, it might look different than those who are cognitively normal, but to the best of their ability, making sure that they are integrated into their social circle. And then supports for both patients who might want to talk to other people with epilepsy, but also for caregivers, because having sort of that social support and making sure they're having discussions about this and sort of learning from each other can be really, really helpful. Mental health is also an important point to talk about in adolescence. Both epilepsy and seizure medications can cause alterations in mood. There are higher rates of anxiety and depression in patients with epilepsy. Like I was saying before, social isolation is more common in patients with epilepsy, which can put patients at higher risk for mental health issues. And then mental health issues themselves can have effects on medication compliance, sleep, and their just overall health maintenance. And so making sure that mental health issues are being addressed is really important. Therapy is really, really important, whatever kind of therapy is appropriate for your kid. But there are medication options. Most mental health and psychiatry medications are safe. There's always a question about ADHD medicines. Those seem to be very, very safe in most patients with epilepsy. Antidepressants are very, very safe. There are a couple that you want to make sure to avoid. Talk to your physician about before starting any medication. The one that I just like to bring up is a commonly used one. It's called bupropion. It can be used to treat depression, but it can increase the risk of seizures. So that's one I like to avoid personally, but talk to your provider about any concerns for that. Lastly, socially, there is still, unfortunately, stigma around patients with epilepsy. Encouraging your teens and getting their friends and classmates sort of to break down that stigma is really helpful. There are epilepsy awareness days. There's education for friends, classmates, teachers through different organizations such as the Epilepsy Foundation. Sharing with their diagnosis with friends can reduce isolation and stigma that way. There are lots of things, not all of it's correct information on social media. There's also non-epileptic seizures, things like psychogenic or functional neurologic disorders that there's a lot of stigma about too, and there's often overlap between epilepsy and non-epileptic events. And so making people aware of their diagnosis and what they have is also really, really important. So that was a pretty fast overview, I think, of many different areas. So thank you all for listening, and I hope this was helpful, but I would love to hear any questions you all have or any discussion about anything I've brought up.
I do have a question.
Yeah.
Okay, so I have, what about epileptic children that are nonverbal? Not even that. There's a caveat. Well, we have another issue. She also has hemiparesis. So my child doesn't use a certain side of her body. So therefore she'll most likely be living with us for the rest of her life. So
yeah, that's a great question. So for those sort of for patients like your daughter, making sure that guardianship and insurance is set up early is really, really important. And so there are many different resources, but the guardianship and planning for that is really, really important. And then depending on sort of the specific situations, often talking to an adolescent medicine doctor who has often experience with patients with intellectual disability or motor impairments, that can be really helpful because things like birth control in a nonverbal kid who also has mobility issues is a really sort of often an important part of their care. And so I think this is where it's multidisciplinary. And so we're often going to be, as the neurologists, a sort of quarterback for that care, but making sure you're getting into those different specialties is really important. The guardianship is really, really key, and then followed up by what options are there. There are group living arrangements. There's also people, live with their parents, but planning for the future is often important. And the first stop I always think is your physician and social work, and then going from there, some of the other advocacy organizations to find out what options are available.
Okay, so those are the resources that I would do in my situation to prepare for this.
Correct.
Okay, thank you.
No worries.
Yeah, another thing I just wanted to jump into is in the school setting is or if your child has an IEP,
Yep.
transition planning is a part of the IEP, and it's something that schools don't necessarily always bring up. So a lot of parents aren't even aware that that's a required part of their IEP, but that is something that's supposed to start in the early teen years and is a process of setting goals and determining services for the transition to adulthood. And in Michigan, you can continue to receive services through special education through an IEP up until age 26. So that is an option to explore as well.
Thank you very much for that. I did not know that. Appreciate that.
Thank you, Russ. That's great.
Other questions?
Just curious, I know you've mentioned starting early for guardianship and planning for the future and regarding insurance as well. And I know it probably depends child by child and case by case, but what would be, does it take a year, 2 years? What would you?
I would say about I usually encourage patients when they turn 17 to start it because it usually doesn't take a full year, but it could take up to a year. But I do. It's usually starting the process, getting the paperwork and putting in the application is starting to prepare that around 17 is the appropriate time. But you might need some medical documentation or things like that. And so starting at 17, I think, is the appropriate time.
Okay, great. Thank you.
No worries.
Other questions or thoughts or comments or recommendations or suggestions as well?
Yes, I'm always happy to hear. I want to learn from you all as well. So if you have any things to add, if I give this again, I would love to hear.
One thing I'll mention is along with driving, obviously seizure control is one of the important things, but can you talk a little bit about some of the other factors that are involved in the decision of whether it's safe for a teen to drive?
Thank you for bringing that up, Russ. So there, in addition to the seizure control, other things that play into whether or not kids can drive is their sort of their cognitive abilities, their vision, and their attention. And so often, if there's a question about that, getting evaluated with things like neuropsych testing as well as vision testing can be really important in making sure that people are safe. So, for example, some kids with epilepsy may have had a prenatal stroke or some kind of injury that might have affected their vision, and they haven't had formal sort of visual field testing. And so that's important to know, because if a patient with epilepsy also has neglect on one side of their body, it probably isn't a good idea to be able to let them drive. So there are both emotional, cognitive, and visual concerns. And then with patients with epilepsy, they often have some motor issues, and so there might need to be modifications about how the car is shifted, as with kids with other sort of motor disabilities, even without epilepsy, and so that's another consideration.
Great. And I added in a link to the occupational therapy program at Mott. They do have a program called Drivability, and they will do evaluations for driving for anyone who would like to know if that's a safe activity.
Angie, thank you for bringing that up. I did not. I had plans on finding some resources for that, and maybe Russ actually knows some more. But financial planning is a huge component, and so I that is a gap in my knowledge, and I don't know if Russ has any resources for that. I will also personally look and see what I can get to Russ and get that to you, Angie. So thank you for bringing that up.
Yeah, and our Sam Schubert, who's our social worker, is also a great resource for learning more about that.
Hey, Eric, I have a question about driving. So, you had talked about, and this is something I was thinking about before the call anyways, but so if we have a child and he's gone 6 months, 7, 8 months without a seizure, and it's felt like he can drive, but at the same time he's gaining weight, it seems like how does that get addressed, right?
Yes. So that's one of our many difficulties with these sort of situations. And so how I approach it is I want to be alerted to any big changes in weight. But second of all, if a kid is old enough to drive, they usually are around the adult weight anyways. And so I like to make sure that the dosing is at least the minimum adult dose, because adult doses usually aren't weight-based. And so if it's an appropriate weight-based dose for now, and it's above the minimum adult dose, then I think it's usually okay to drive. But you're right, that is a huge concern. But I think the best we have is making sure that they're on an adult dose and an appropriate weight-based dose. And if both of those conditions are met, then they are safe. The other thing that reminded me that I didn't talk about is that there aren't, again, specific guidelines on this, but here our general practice is once we make a medication change, specifically a decrease or weaning off of medicines, we usually require 6 months of seizure freedom before allowing to drive again. And so for kids who are really motivated to get off of medications, that they have been seizure free for a significant period of time, talk to your physician early, because getting off the medicine before they start driving rather than when they've been driving a couple of years and then need to wait 6 months after coming off of medicine can be really disruptive. And so yes, making sure the medications are appropriately dosed and checking in if there's rapid weight gain, letting your doctor know so they can make that change, but also making sure that it's okay on the adult dosing as well, is really important. And on the flip side, when weaning medicines, it can be disruptive to life and driving. And so keep that in mind when making those decisions. Last minute questions?
I have a last minute question.
Yeah.
Um, so with adolescents, often they want to go hang out at their friend's house. And we're fairly new at this. So we're only, a little over, so probably maybe 7 to 8 months into it. And that makes, I think, us very uncomfortable at this point. And I know you did touch on this a bit, talking about camps and college, but what about this, just, oh, I'm going to go hang out at my friend's house, or I want to stay overnight. And again, it seems like, well, someone in that house needs to keep an eye on you. Someone in that house needs to be trained. You need to have your rescue med there. And it just all of a sudden feels very complicated. But of course, we would insist on that. So I guess what have you seen? And I know everyone's different, but do you have any kind of advice or guidelines around that?
Yeah, it's often, very tailored to the specific situation. I will say that in kids that I take care of that are going to especially sleepovers, I I always encourage the parent at the house to be able to at least have the rescue medicine and be sort of told what to do with it, especially now that we are very fortunate to now have nasal spray options that we did not have 10 years ago is great. And so it's very easy to teach somebody how to do the nasal spray. But I think that's sort of the minimum for more of an overnight an overnight stay. I will say that I think as parents, you definitely are going to be very vigilant and wanting to sort of protect your kid at every time. I don't think even at school, unfortunately, that there's going to be somebody at every moment watching with a rescue medicine ready. So short visits for a couple hours with friends, I think is part of life, and I think it's one of the small areas. But having their friends know how to call 911, I think is as good of a option as you have, and allowing them to live their life. I know it's not an easy answer, but it's not an easy one to tease out, because you want to balance protecting them with them having a life, and it's often makes either the kid or the parent more uncomfortable, and balancing that is very, very hard.
Thanks.
Okay, well, it is 1 o'clock, so we will wrap it up. And thank you so much, Dr. Armour, for a very thorough presentation of a huge topic. So you covered a lot of the really important points, and thank you everyone for joining us and for your great questions and comments. This will be added to our YouTube channel, so you can certainly go back and watch it again, or share it with others who you think might find it helpful. So thanks again, Dr. Armour, and everyone have a great day.
Thank you all.
Thanks.